Welcome, everybody. We're here for an interview with Dr. Will Kingston. Hi, Will. Thanks for joining us today.
Yeah, of course. Thanks for having me.
Well, I'm going to read a little bit of a bio about you because you've been doing some amazing things for the pregnancy community in Canada. So, for everyone who's watching, Dr. Kingston is originally from Moncton, New Brunswick, which is how I am lucky enough to know him. He completed his undergraduate education at Queen's University and medical school at Saba University School of Medicine. He completed adult neurology at the University of Toronto, where he has also served as chief resident. He then went on to headache medicine fellowship at the Mayo Clinic in Arizona. Much better weather there than in Toronto, I would imagine. He is currently practicing as a full-time academic neurologist and a headache specialist at Sunnybrook Health Science Centre and assistant professor of neurology at the University of Toronto. He's very busy. He is the site director for the education for the adult neurology residency program. He founded the first dedicated headache in pregnancy clinic in Canada and possibly in the world, which continues to grow. His clinical interests are in cluster headaches and headache in pregnancy. He's currently on the board of the Canadian Headache Society. So Dr. Kingston's specialty here with his involvement in headaches during pregnancy really piqued my interest because certainly as a women's health clinic, that's what we're seeing a lot. And we'd love to know more about this really innovative program that you've come up with. So if you would be so kind, Dr. Kingston, could you please tell me what motivated you to open this clinic that's dedicated to headache during pregnancy?
Yeah, of course. I mean, I could talk about this topic all day. I think a lot of the reasons why I wanted to start this are the reasons why I wanted to go to into headache medicine in the first place, is because it's so common and so many people are uncomfortable treating such a common problem in such a common setting. And I had so many pregnant people, show up and dawning my doors saying that even their regular neurologist, or in some cases even a headache specialist, was uncomfortable treating them. And in my head, I right away was thinking, well, if your doctor is uncomfortable treating you, then who the heck are you going to ask for help? And I think what I found over time and with really sort of establishing more of an expertise in this is that most, not all, but most people just having that knowledge that there's someone there helping them is therapeutic in and of itself. Like, so it doesn't always mean that it is a lot of drugs, and it doesn't mean that it's always a lot of intervention, but it means that even small things can make a big difference. So that's really what's motivated me.
I think that's a very common theme that we see in women's health in general, and in pregnancies in particular, with many different disciplines, that sometimes practitioners are not comfortable treating pregnant women because it goes above and beyond maybe what our standard education was.
Yeah, of course. I mean, and to piggyback on that, migraine, for example, which is far and away the most common type of headache disorder that we see in clinical practice, and definitely the most common we see in pregnancy. But migraine affects anywhere from, depending what study you read, 15 to 18% of the world, and upwards of 20% of all women. So when something that common, you're going to see it in pregnancy no matter what, right?
Right. So whether you choose to specialize it or not, you're either just kind of ignoring this large portion of the population that could be seeking care from you.
That's right.
Do you want to maybe cover what some of the typical causes are for headache during pregnancy and whether they're the same as someone who isn't pregnant, or are there special considerations for the pregnant population?
I'm really glad you asked that. And I think it's a really important jump in point to kind of talk about cause versus exacerbation, or cause versus trigger, even though I don't love that word. Again, migraine, I'll speak mostly about migraine since it's over 90% of what we would see in the pregnant population.
Sure.
Migraine essentially is a condition that people are born with a susceptibility towards. So we look at it being essentially a genetic disorder, but it's one that ebbs and flows throughout one's life. So you could have years without actually having symptoms of migraine, but if you have ever had migraine, you will always have migraine. And migraine is a condition that really loves routine, and sometimes you can do everything right and you'll still get a migraine attack, but pregnancy is a time where there's so much flux, both externally, internally. Not only is your body changing, not only is there hormonal components, which most definitely can play a part for some pregnant people, but there's also changes in your life. There's changes with your work schedule. There's preparing for a new human in your house. So all of these things can really impact how migraine behaves during pregnancy. And sorry for the feline interruption here. We also know that for the most part, when we research migraine in pregnancy, most people will improve, but usually they improve towards the latter half of pregnancy. We do believe that there is some hormonal components associated with that, which I could get into the weeds about, but we don't need to necessarily. But sometimes before people get better, they may get a little worse. And particularly in that first and maybe even early second trimester is where I see people have the most problems. And some of that is true worsening because the problem is getting a little worse because there's so many hormonal fluctuations, changes with your life. But it's also the lack and loss of previous compensatory mechanisms that people have established, right? So you have someone who said, I've had migraine since I was 7 years old, and I know this works for me. And then suddenly they're pregnant and they think, oh no, like, what do I do? Can I take something? And then there's the guilt that people feel if they need to take something. And all of those things are things that I have to tackle with these folks.
Right. I think that's a really good point. And again, like very common themes that you see with other illnesses or other conditions is that there's a lot of just uncertainty in the pregnant person themselves about what they should do with the condition, even though they're familiar with the condition and they know what they would have done in the past, they don't know what to do during pregnancy.
That's
So
right.
do you find that quite challenging? Or are there other challenges that you encounter when trying to treat migraine or headaches with a pregnant population?
Yeah, I mean, there is. I mean, even when you're, to be honest, pregnant people, just like any patient, is not a hapless victim to their condition. They're informed individuals who are capable of making decisions, but they need guidance on how to make those decisions. And I also always have to recognize that as someone who will never be pregnant, that hearing it from someone like me may not always resonate the same way. So I always acknowledge that. First of all.
Which is so kind of you. Thank you for taking the time to do that, because I do think that sometimes as women navigating the healthcare system, that's not always the case, right?
Yeah, I mean, I think the last thing someone needs is to be mansplained about how to be pregnant. And I don't think that's helpful. But I also, like I mentioned, the guilt of treating something, and sometimes even when I talk through with someone about what are safe options or reasonably safe options and things that I would perceive to be reasonable, sometimes, the psychological guilt of I don't want to take anything, I don't want to put anything in my body is a hard hurdle to overcome. So one of the challenges that I have to then educate someone about is, having a migraine and being sick and vomiting and in bed for 2-3 days is also not good for a growing baby. And I think those are things that we have to kind of look at as well. I think one of the problems that I sometimes face in the medical community at large is migraine, whether it's in a pregnant person or a non-pregnant person, is often just not taken seriously enough. Not to say that migraine will lead to death or anything like that, but it's one of the single most important causes of years lived with disability. In fact, the World Health Organization has recognized it as the third most disabling condition that exists in the world. So I think it's important to note that migraine is not just like an innocent bystander in pregnancy, because we know that really frequent and untreated migraine has a higher risk of low birth weight. It has a higher risk of intrauterine growth restrictions. So it's not like migraine in and of itself is benign necessarily. So we just want to make sure that we don't forget that.
Right. But because it's not life-threatening per se, it might not get the attention that other conditions might see.
Correct. And I think the pervasive opinion that it's just a headache is so foolish. It's just not true.
Well, it's a quality of life problem.
Right. And while headache is the most common and prevalent and often most disabling symptom associated with migraine, there's certainly a whole lot more that comes with it. There's nausea, there's light sensitivity. Sometimes people experience some cognitive symptoms. Some people have aura where they'll have neurological symptoms with their headache. So, and those can all be reasons why people end up not understanding what's going on and actually go to the hospital. And the last thing we want is people going to the hospital, unnecessarily, for lots of reasons, especially the last few years, right?
Yeah. Okay, so could you maybe walk me through what some pharmaceutical options are available to the pregnant population? Because I think there's a lot of confusion about what someone can take when they're pregnant. And I know you're not giving me any, specifics. You have to, sit down with the patient, but can you give me some ideas? Like, are there medications out there that women could be using?
Of course, yeah, no, I'm happy to, because this is largely what I focus my discussions
Yeah.
on too. The truth is, someone probably wouldn't dawn my door if they didn't at least need to have a bit of a discussion on what some pharmaceutical options are. So I think it's a really fair question. But I will put a caveat that, always speak with your medical practitioner before, asking for specific prescriptions. So it's a complicated question in that there's two ways that we treat headache in general. There's two strategies. One is what we call prevention, and prevention is really aimed at reducing the burden of migraine. So what do we do on a day-to-day basis to reduce the overall burden? Lifestyle is one, sleep, meditation, but many people with frequent headache actually do need preventive medications to help reduce the burden of headache. That is where I face a little bit more challenge when dealing with the pregnant population, because it is a daily medication a lot of the time. But there is a few different options. So in the earlier stages of pregnancy, we know that beta blockers, specifically propranolol, has been around forever. So we have some reasonable safety data on that. And then there's some lesser used medications for migraine, but easier to use in pregnancy. One is called cyproheptadine. It's a medication actually we use to prevent migraine in children. And it also can help stimulate appetite. So it can be good for people who have a lot of nausea associated with their pregnancy. And then there's another one called, it's called memantine, which originally was designed as a dementia drug. So how we found out it was okay in pregnancy is hard for me to understand. But in any case, we also use that occasionally as well. And then there can be interventional procedures like nerve blocks, where we inject lidocaine towards the back of the head where the head meets the neck. And that's less systemic. So sometimes it's favored by people with really frequent headache during pregnancy. So that's the prevention piece. And again, that's sort of it's not a one size fits all kind of recipe. Where what we deal with more commonly, because everyone, even whether they have a lower frequency of headache or a higher frequency of headache, needs something to what we call abortive treatment or rescue treatment, what you do in the moment to try to get your day back. The single most commonly used class of medications for migraine in terms of prescription medications would be called triptans. They've been around since the 90s. We actually have a lot of reasonable safety data on them. And the one that we default to most often is one called sumatriptan, not because it's necessarily safe than the other ones, it's because it's been around the longest, so we have the most registry data on it. And the caveat that I'll put is that it's never ethical to enroll a pregnant person into a clinical trial. So all of our safety data we have comes from anecdotal evidence and from registries rather than a specific trial. So that always presents a little bit more of a challenge when counseling things. But by and large, most people do believe that medicines like sumatriptan are quite safe in pregnancy, except for very specific circumstances. And then, run-of-the-mill acetaminophen or Tylenol, as most people would know it, is reasonable, but most people have tried that by the time they see me. But even using something like Tylenol Ultra, which is Tylenol with a bit of caffeine in it, can sometimes be more effective. So little things like that.
Thank you for sharing that. I think that's incredibly important for people to hear, that there are pharmaceutical options available to them.
And those are first line ones too, Katie. Like there's actually some others we would also consider if they weren't effective or for whatever reason, we couldn't use those ones that I just mentioned. There are other things to consider too, but those are sort of our first go-tos.
And do you find your colleagues in the obstetrical community are confident in prescribing those? Is that something that needs, do you feel like that's a competency that they're being educated with, or is there some information that needs to be more broadly applied across, the physicians in Canada?
Yeah, no, I think in general, so there's some scary statistics. A lot of them come out of the US, but most practitioners, most people in medical school only get an average of about 2 to 3 hours of headache education throughout their entire medical training. And migraine accounts for about 9 to 10% of all primary care and emergency room visits. So we're vastly undertreated.
The balance is off there.
Undereducated. And obstetrics and OBGYNs are no exception to that rule, because they're focusing on other things. They haven't, really encountered this, but they encounter this problem all the time. So to answer your question, is they're usually not all that comfortable prescribing it. And that's sort of where I started this clinic it really started as a direct referral source directly from our OBGYNs at Sunnybrook. And that's still where the bulk of my referrals come from, because I sort of have a direct kind of flow right from them. And I think all of them so far have been pretty comfortable with the discussions that I've had with them about. But to answer your question, it's usually me that's making that prescription, not the obstetric, not the obstetrician.
And you find the clinic's been well received, basically?
It seems to be very well received, yeah, because I think they've all recognized what a common problem it is, and how much they've needed help with this.
I find it really enlightening that you were mentioning lifestyle modifications. Can
Yeah.
you talk to me about that a little bit as well? Because from a physio perspective, that's something that we can easily discuss with our pregnant population that we're seeing.
Yeah, and even your non-pregnant population.
Right.
There's a couple things that I like to tell people to do. First of all, you know, and I know I'm veering off a little bit first, but it's okay. You know, I was told by a mentor of mine that a headache history is hearsay, but a diary is evidence. So one thing that I would say, if you're ever looking for help with your headaches, even before you even embark on changes to your lifestyle, we need to know what you were like before you started anything. So tracking your headaches is really helpful. And a good strategy that we use is what we call the stoplight system. So a red headache means it's so bad you have to stop what you're doing. A yellow headache means it's bad enough that you have to slow down but can do some things. A green headache is a nuisance. No color means you had no headache that day. You don't need to track it. There's a free, very easy to use app called the Canadian Migraine Tracker that can help you do this. And then it allows you to see if the interventions you've made are getting better, because the truth is it always seems as bad as your last headache, and we're not always the best at determining whether or not we're doing better without a little bit of hard data. And that's why we ask people to do that. We don't need you to track all of the tiny minutiae, but starting with just basic red, yellow, green, and the number of your headache days and what you've done. That's often good enough. Now, when it comes to specific lifestyle interventions, the problem we run into with migraine is it's such a common disorder that everyone has heard, oh, well, my Aunt June said to do this, so I'm going to do that. And then someone else will say something completely, off the wall. And the truth is it's such a heterogeneous disorder that for some people, those things may work, but we can't really always validate that with science. But there is a few things that we have shown that are effective when it comes to lifestyle modifications. Sleep is like another medicine for headache. So trying your best for a routine sleep schedule, so similar bedtimes and similar wake times every night, whenever possible, within about an hour of of each other. Trying to stay adequately hydrated, which is even more important for someone who's pregnant. Not skipping meals. So fasting is probably a very bad strategy for people who have migraine. And then we know that probably, and a recent study suggests it may be the most important intervention, it's exercise. And that's a really hard thing to tell someone, because by definition, migraine is a headache that's often made worse with routine physical activity. And if someone has really frequent headache, it can be a really big barrier to exercise. So one thing that I'll tell people is, even if you start low and go slow, that is a better way to do it. You're not doing damage to yourself if you make a headache a bit worse with exercise. So, push a little harder on days where you're not feeling well, and ease it in again on days that you are feeling well, so that you don't overdo it and then pay for it for a few days afterwards. So it's really about moderation, but introducing exercise is incredibly important. And then the last things are, there was a study published just in 2021 by a colleague of mine in the States that showed the benefits of mindfulness-based stress reduction strategies. And where that interventions have made the biggest difference is not necessarily on the number of headache days or the headache severity per se, but it reduces how much it impacts your life. So strategies like that can help people with coping incredibly. So I highly recommend sort of all of those things in general to everyone, regardless of their frequency of their migraine, because those are easy things to, well, when I say easy, I recognize that people can't change overnight, but they're safe, low impact things that just about anybody can do.
And was there a specific on the exercise recommendation, whether it's cardiovascular exercise, with resistance training, or was it just move your body?
Yeah, it's most of the stuff that we have is mostly with cardiovascular stuff as opposed to resistance. That doesn't mean, I think essentially what it is getting your heart rate up and doing some degree of moderate exercise. We say usually about 30 minutes, 5 days a week is the ideal if we can. I know that's not an easy attainable goal for everyone, but it's something to at least start with. And, I think even if someone is doing mild exercise 30 minutes, 5 days a week, and that gives them something to build upon to get to that moderate intensity.
No, I think that's really with the pregnant population, you're meeting them at a time where they're already considering lifestyle changes, I think, from, healthy behaviors in order to optimize pregnancy and the health of their child. And so that might be a way, like a foot through the door if they're already considering those types of things. It's a good time in their life to have that chat with them.
Very much so. And of course, there's obviously going to be a caveat, like if you're dealing with cervical insufficiency or,
Yeah.
other things that could, threaten a pregnancy. Of course, that's not the same recommendation for people like that. But otherwise, these interventions are absolutely things that can be instituted during pregnancy too. Yeah.
Right. Are there any red flags that you think that either lay people should be looking for or general practitioners should be monitoring for in their patients where it might warrant having, a more thorough discussion with someone who has more knowledge in headache and migraine?
Yeah, I mean, in general, and this is true of people who are pregnant and not pregnant, but we always kind of keep a little bit of an eyebrow up when someone is pregnant because it is a riskier state in general. I would say there's a mnemonic that we use when we teach residents and medical students about how to look for red flags on headache. And so a couple of them that I'll highlight, I won't go through all of them, but essentially if someone has had an established pattern of headache forever and it suddenly changes without warning, that would be a reason to seek a little bit more help. A new headache in like later stages of pregnancy should absolutely be taken seriously, and someone may actually want to present more emergently if that happens. If it's the same exact headache that's always been happening, but just a touch more frequently, that's probably not a red flag, and probably just is something to do with routine changes we see in pregnancy. But again, if it's feeling totally different, you should get checked out. The other is what we call a thunderclap headache, and that by definition means a headache that starts and then reaches its peak intensity within less than 1 minute. So basically, a headache that starts, like a bat out of hell. That's something that we really do need to take seriously, and that's something that actually warrants more emergent imaging and probably should be assessed best in the emergency room. And the other thing that I'll say too is, especially for the pregnant population, one of the things when I do encounter headaches that I'm worried about, which thankfully is not terribly frequently, is people worry about, oh no, can I get imaged? Can I have a test when I'm pregnant? And that's a complicated answer, but the easiest way to put it is, if this is something that could be serious or life-threatening, the truth is we have to do what gets you looked at the fastest. And while we do usually try to avoid radiation and prefer MRI as opposed to a CAT scan or a CT scan, we call it, we prefer MRI when we can and when we have time. But if it's an emergency situation, sometimes we do have to go right to a CT scan, and that's why. Because if someone is having a life-threatening event, their pregnancy would also be threatened.
Right.
And I think that's something we have to just bear in mind.
I think that's good sense. Is there anything that we should be considering for the postpartum population? Are there any things that change postpartum?
There is. So, for what it's worth, as I mentioned, most people who have migraine and then get pregnant, they usually do get better in the later stages of pregnancy. And the same data applies for people who choose to breastfeed or are able to breastfeed. I know lots of people try and are not successful, and it's not your fault if you can't. Some people just can't. But if you're able to and you have bad migraine, it might actually give you some extra protection. So there's maybe
The
that
breastfeeding, like lactation, provides extra protection. Is that from a hormone perspective that you think?
Yeah, we think so. Yeah, we think so. The exact mechanisms are probably a little more complicated than just hormones, but we certainly do think it's been shown to be helpful. Now, how long that will be helpful for is different for every person. And it also changes because different medications we may use preferentially in lactation compared with pregnancy. Lactation does open the doors a little bit more for more options. And for example, I mentioned a medicine called sumatriptan that we usually use during pregnancy. We often switch it to one called elatriptan when someone is lactating, because that one is excreted in far fewer amounts and far less amounts in breast milk compared with sumatriptan.
Okay.
So, if someone has frequent headache, and is no longer pregnant but is still lactating, there may be other preventive treatments, other preventive medications that we would use in lactation, but not necessarily in pregnancy, and vice versa.
And I would assume that this would be ongoing care in the postpartum community because they, again, don't have a regular sleeping pattern. They've got new stress. Like, I can see how that would be a challenging population to work with. It doesn't just end in pregnancy. It's kind of getting through like the early mummy years, I guess.
That's exactly right. And with my pregnancy clinic, one of the things that we automatically do is we actually book them for a final pregnancy appointment about 2 weeks before their due date, so that we can get them prepped for when they've delivered and when they are, if they're lactating, so that they can have the appropriate prescriptions if they need prescriptions, and are not rushing to the pharmacy, with a newborn.
That is brilliant. Like you're doing their acute postpartum care at the later stages of pregnancy. Oh my
Yeah,
gosh, that's fantastic.
just so they can be prepared, because I can't imagine. I mean, not everyone has a partner that can go to the pharmacy for them too, right? So
Yeah.
it's
Tricky. It's a tricky time of life for sure.
hmm.
That's wonderful. Is there anything else that you think you should mention that I haven't brought up already?
I think we've covered just about everything. I think if there's one thing that I can just say is that, you know, if you're a layperson and you're dealing with frequent headaches, there's great resources. There's the Canadian Headache Society. There's Migraine Canada. Migraine Canada has really great patient advocacy stuff. They have really great patient resources. There's the American Migraine Foundation and the American Headache Society. Sorry, my cat just pressed the volume button on my TV. And then otherwise, talk to your doctor, and because it is a treatable problem. It's not a curable problem, but it's definitely a treatable problem, and it's something that we can often do better with. I would say if you are someone who is dealing with headache, be weary of a couple of things. If you're prescribed opiate medications, think twice about using them, because most of the data we have suggests they are harmful, not helpful. So anything that's codeine, hydromorphone, morphine, generally really bad choices for headache, and you should maybe think about getting another opinion if your doctor's prescribing those things. The other is to recognize that it's important. And if you're a healthcare provider and you want to learn more about migraine, there's lots of opportunities. So the Canadian Neurosciences Federation, there's teaching courses through that. There is annual meetings from both from the American Headache Society, specifically one called the Scottsdale Headache Symposium. It's a great place for physicians, nurses, allied health members to actually learn about ways they can help headache patients. So there's lots of opportunities for continuing professional development in this field as well.
And if people want to be referred to your clinic, who are either closer to your location, or if they need to reach out to you, is there a way to do that at all?
Yeah. So generally speaking, if you're in the Toronto area, your family physician can send a referral to my office. At the moment, because of massive wait times, if you're a non-pregnant individual, I usually tell people to go to the closest neurologist or headache specialist in their catchment. So if you're not in mine, then I would probably only be able to accept it if someone was pregnant, since that's my expertise. But if you're seeing a neurologist elsewhere and they need help from someone like me, the neurologist could reach out to me directly.
Oh, that's awesome. That's amazing. Listen, thank you so much for your time. We really appreciate it. I think everyone that's watching this video has learned a tremendous amount. And I think it's just gone on to highlight the importance of really managing headache and to being aware of those symptoms within our patients, and for the patients themselves to feel like the confidence that they can approach their provider about that issue. So thank you once again, and hopefully we'll hear from you in the future sometime, right?
That'd be great. Sorry for all the feline interruptions, and
That's okay.
Thanks
It was
for
cute. It was worth the interruption.
Yeah. Thanks for everything you do, Katie, as well. I think your posts are really, really great.
Someday I'll do a TikTok with you. I'm going to stop the recording here.